The bitch.
Mr. Gomez, your respirations are 15 and I hear crackles in your lungs. Can you tell me the name of the hospital or today's date?
Not the hospital.
Can you tell me the name of the hospital?
I'm just too tired.
Skip. Next. Okay. Nurse Allison assessed Mr. Gomez's respiratory status. Which of the following actions should a nurse take? I put call the respiratory therapist to administer the prescription of albuterol. Why I picked that is because the whole case study is about him having exacerbated COPD. Guess what the fucking answer was? Because that's not the right answer. Y'all want to know what the right fucking answer is? Place Mr. Gomez on a non-rebreather mask? No. Wrong. Because they said it decreases the respiratory drive, which already compromised and causes COPD. Like, a bitch don't fucking know that. Decrease the rate of oxygen flow. Decreasing the rate of oxygen flow is the most appropriate action because the lowest possible rate maintains oxygen status without depressing the respiratory drive. The client who has COPD with hypoxemia requires lower levels of oxygen delivery, usually in the range of 1 to 2 liters per minute. Some clients are chronic CO2 retainers, hypercapnia, and can be more oxygen sensitive, so too much oxygen increased CO2 retention can result in lower respiratory rates. Fucking knew that, I would have chose that. But y'all, this is why I hate ATI, because it's like, damn if you do, damn if you don't. Like, what the fuck? Nothing when y'all watch that video and I watch that video, crackle in the lungs. That can be, don't get me wrong, that can be, but it's like, okay, I would have knew, that's what I'm saying. No, it never said anything about the oxygen saturation being high, and plus, you have a nasal cannula on, so I know it only could go like 1 to 6 liters per minute, so I know that, but my thing is, like, come on now, y'all need to be more specific of what y'all asking, because now I'm finna fucking fail this thing, and I have to redo this hour-long shit, because y'all not being specific of what y'all talking about. Y'all just, it's so broad. After that being assessed, what would you do next? Okay, I'm saying, is he can't breathe? Do he got too much oxygen? Y'all say he got too much oxygen. Nothing that it said that. It didn't say nothing about that. He's leaning over on the table trying to catch his motherfucking breath. If a bitch is leaning over on the table like normal COP do to try to catch a bitch breath, what the fuck do you think that means? The bitch can't breathe. So what the fuck does... Alright, I'm trying to see, okay, because it said in his chart that he need albuterol, and I'm like, damn, but probably he need a motherfucking breathing treatment, because that's what mostly fucking COPD patients have, is breathing treatment. If you would tell a bitch that, a bitch would have picked that. That's what I'm talking about. Like, this shit is, this is not nursing. This is not motherfucking nursing. This is not nursing. Like, come on now. Where is my patho book? I need to go on my patho book and just like, hold on. I'm gonna prove a point. I didn't want to pick up this cursed book because I passed this class already with an A, but motherfucker, it's time to go back to the basics, y'all know. Fuck. Bad look. I'm stressed as fuck doing this shit. Look at my coffee. Let me flip through this shit. Sick of this motherfucking school. The fuck I need to be a nurse while I'm a whole goddamn engineer. Fuck. Already white ass. Now I'm trying to take care of a bitch. And every time I do, the shit don't fucking work. Asthma, I'm getting close. What the fuck COPD at? There we go. Chronic obstructive pulmonary disease. But I'm digging in my nose. COPD describes a group of chronic respiratory disorders characterized by irreversible progressive tissue degenerator and airway obstruction. What the fuck do you think an albuterol does? Keep fucking reading. These debilitating conditions can impair an individual's ability to work and function independently. The most significant contributing factors of COPD is cigarette smoking. Like, a bitch don't know that. Put them pokes down. Other contributing factors include inhalation of pollution and chemical irritants. Y'all, bitch, I think I found my point. The information appears to be a modification of the normal inflammatory responses, though it is not fully understood. Oxidative stress and increased proteinuria in the lungs play a likely role. The imbalance between proteas and antiproteinase is the breakdown. Hold on. Y'all ready to hear this? With COPD ventilation. Hold on, let me show y'all because I need evidence-based practice. Come on, babe. With COPD, ventilation is impaired because of one of the most following. The airway of the alveoli lose elasticity. The walls between the alveoli are destroyed. The walls between the airway became thick and inflamed. Mucus production increased and blocked the airway. Severe hypoxia and hypercapnia can lead to respiratory failure. The chronic hypercapnia shifts the normal breathing drive from the need to expel excess carbon dioxide to need to raise the oxygen level. Systematic inflammation may be presented, could play a role in multiple comorbidities, meaning different diseases, conditions found in patients with COPD. Additionally, COPD can lead to cold pulmonary, a type of right-sided heart failure due to lung disease. Okay. That's my fucking point, and that's why if we could go back to ATI, and chose that. If think about it for a second, they have to do pursed lip breathing because they have too much carbon dioxide in their body. Why the fuck will I give them too much oxygen if they have an exacerbated fucking COPD? I'm only doing that because they have respiratory failure, but then they talk about some decreasing. How would you decrease something if the man can't motherfucking breathe? You can tell in the video that he's leaning over the counter. That's what I'm talking about. This is what I'm talking about. They grade us on this. We read one thing in another book, but then you got to go by ATI. That's what I'm saying. I might be wrong, y'all. Y'all nurses, y'all be in my comments and y'all try to prove me wrong. Because, motherfucker, I'm reading through the book and I'm trying to do this shit and I understand that, but ATI didn't say nothing about this man was on so much on like a 5-6 liter of oxygen. It never said that. So if he leaned over the counter trying to catch his breath, he either have too much oxygen in his body or too much carbon dioxide. And of course, with COPD, you have too much carbon dioxide built up in your fucking body. Wait, hold on. Excess. Hold on. Yeah, because hypercapnia is a hypoxia, low oxygen, and hypercapnia. A lot of carbon dioxide in your body. So when you want to open up the airways, because he haven't exacerbated, meaning like a bad song. I just want to cut somebody out because of this. Me cussing you out. And leave in the comments below. Maybe I'm overreacting, but baby, have y'all on Netflix seen The Good Nurse? The fuck? I'm that bitch. Not the man that was killed the patient. I don't know why. It's crazy I was doing it. I'm the bitch that was saving the patient. I just want to talk my shit. Because, baby, I know what the fuck I read, bitch. If I had to pull out this motherfucking patho book from last quarter, it's a problem. Now take your ass to bed. I bitch know when the bitch wrong. So let me show y'all something. Depending on what type of motherfucking COP he got, do he got chronic bronchitis or do he have emphysema? It says right here, treatment strategies include oxygen therapy in limited amounts because too much will knock out the newly oxygenated center drive for breathing. Bronchodilators, which I chose. Corticosteroid antibiotics, which I also chose. If bacterial infection is present. Oh. Postural drainage, meaning like, you know, like the position, like to drain your nose and shit. And chest physiotherapy increase. A bitch know when they wrong. You see how stupid I look? So what? I still looked in the book. So y'all better give me credit.